About 285 million people are visually impaired worldwide. With proper care, 80% of the global burden is curable or preventable. Outreach programs, namely iCamps, are aimed at reaching all in need, prioritizing improving access to care in underserved populations. Arvind's iCamp approach to outreach is a cost-effective way of reaching the unreached, engaging community participation, and creating awareness of eye health in remote and underserviced areas. Arvind's Camp program is a multi-part strategy consisting of comprehensive screening camps, workplace screening camps, school screening camps, diabetic retinopathy screening camps, and pediatric screening camps. Arvind's Camp division is the backbone of these outreach efforts. It is comprised of a camp manager, camp organizers, and administrative support staff. While the camp manager oversees all outreach activity, camp organizers are responsible for coordinating outreach activities in their assigned regions or districts within Arvind's service area. The success of the outreach efforts lies in meticulous planning. Over the years, the camp division has developed a detailed procedure for organizing iCamps. What follows is essentially a checklist that highlights the key components involved in establishing a successful iCamp. After determining a feasible service area for outreach activity, it is essential to understand the eye care needs of the target population. So the first step of the planning process is to research and collect baseline demographic information of the target population. To achieve the goal of providing care to all in need, it is particularly important to recognize the segmentation of the market demand for eye care, to design outreach approaches for subgroups of the target population, such as children, working adults, diabetic patients, and the elderly. Each camp organizer studies demographic statistics of his or her designated area and applies regional estimates of the prevalence of eye disease when designing camp strategies and selecting locations for camps. After pinpointing suitable campsites, the process of engaging community partners, also known as camp sponsors, begins. Community partners are organizations or individuals within the communities that are being served who take ownership of the outreach activity. They can be service organizations, local hospitals, religious organizations, educational institutions, or anyone who is willing and committed to take on responsibilities for establishing an iCamp. Because of their local knowledge and experience, working with community partners is an effective way of reaching large numbers of patients in remote and underserved areas. Finding dedicated community partners is central to the success of Arvind's outreach efforts, so the camp organizer spends time assessing a potential sponsor's capacity and motivation to conduct an iCamp and clarifying the commitments on the part of Arvind and the sponsor community partner. The core of the planning process is centered on strong collaboration between the hospital outreach team and dedicated community partners. Tasks must be delegated clearly and appropriately to ensure the optimal operation and efficiency of the camp. Since the community partner has better knowledge about the area and its residents, they are usually responsible for the major tasks of mobilizing demand for eye care, publicizing the iCamp, and attracting beneficiaries. In addition, the community partner takes on most of the responsibility of choosing an accessible camp venue based on the estimated size of the camp, arranging the facilities of the campsite, and employing volunteers. In turn, the camp manager and organizers prepare the necessary resources such as the clinical team and support staff, equipment, supplies, and transportation for patients to the base hospital. The hospital team and the community partner work together to estimate the size of the camp and its corresponding needs. Camp size is predicted in terms of the number of patients expected to be received and examined at the camp. Though predicting the size of the camp is speculative, turnout generally depends on demographic factors such as population size, age distribution, and prevalence of eye disease in the area, as well as the reach and effectiveness of the publicity campaign. These indicators, along with previous turnout at camps nearby, serve as guidelines for predicting the size of a camp. Depending on the predicted size, facilities, camp personnel, equipment, and supplies, transportation and arrangement for patients who are referred to the base hospital for further treatment are planned accordingly. Thanks to a systematic practice of data collection and evaluation, the Camp Division has developed a standardized methodology for predicting camp size and its corresponding needs, which has streamlined the planning process and improved coordination between the base hospital and the outreach team. A crucial step in pre-camp preparation is deciding what data will be collected during the camp and how it will be recorded to allow for proper monitoring and evaluation of the camp. A standard procedure for monitoring and evaluating has been developed to aid in the planning of future camps. Data collected from every camp are reviewed during an important meeting at the beginning of the year to set patient recruitment targets for the year ahead. Weekly meetings are held throughout the year to review data collected from the previous week's camps and discuss how their outcomes compare to the baseline targets set at the beginning of the year. These meetings are crucial for ensuring the accountability of the outreach team to sponsors and patients, and are a chance for all members of the team to discuss successes and failures, share insights and suggestions, and most importantly, take steps to improve the reach and effectiveness of Aravin's outreach efforts.